Teaching what?
What's obstetrics? Obstetrics pertaining to pregnancy. And then care of the newborn, the brand new baby. So this has a lot to do with childbirth. Care of the baby, there's some things that we'll talk about, although a lot more will be tomorrow when we deal with pediatrics. But for today, we're talking about childbirth. Now, if I haven't taught you guys this yet, and I do mean guys, if I haven't taught you guys this, well, now's the time that I really need to teach it to you. Understand that during this period of time, when she is going through all this pain and misery, she is going to blame us. It's our fault. Okay? It doesn't matter that it takes two to tango. It's our fault. So if you want to have a happy life, accept the reality and the responsibility that it's our fault. Us, ours, and guys. Okay? Don't argue with her. Don't say, but honey, you were there too. No. They kind of forget that part. It's our fault. So accept it now and you'll be happy. Right, ladies?
Everything's always their fault.
Dang.
See?
Yeah, right.
It's our fault that they wanted to get drunk and, you know, a little hokey pokey. It's our fault. Okay. So, with that said, now I highly recommend that you take notes. I am recording already, but really take notes. There's a couple things I love to test on. One of those is the stages of labor. And you can see the stages of labor tests on registry as well. Understand the anatomy of pregnancy. We're going to talk about that. Okay. The procedure, it's a piece of cake. Now, what I do have to say about the procedure is that remember that women were delivering babies long before there was medicine. It's a natural process. If we have to do it, we're there to help out. The only time I've been involved with childbirth has been in a controlled setting when I was in paramedic school. And for all of about 2-3 days, I'm like, I could never do that to a woman. Just seeing the misery and hearing the pain, I'm like, I can't be that mean. And as you guys know, I can't be that mean. And worse. Just kidding. But it's pretty interesting. So again, I apologize. I have my camera off. I'm trying to eat. I don't want you guys to see me eating. If I don't eat now, I usually don't eat at the break. And still, I'm not a well man. I'm a sick man. Great excuses, huh? So, let me see. All right. So, Ashley and Gerardo arrive on the scene of a dispatch for an OB call to find an obviously pregnant woman in her 30s who appears to be uncomfortable and anxious. I'm only 35 weeks, she says. The baby shouldn't be here for another month, but I think they're coming now. Wait, what did she say?
They?
Yeah, there. What's she mean there?
Twins, triplets, that.
Holy cow. I didn't sign up for this stuff. Just kidding. At 35 weeks of gestation, what is the risk of distress if the baby is born now?
Undeveloped lungs.
Not undeveloped.
Well, they're still developing, but
Underdeveloped. What else?
preemie. They're gonna come out as a preemie, so.
And we'll talk about what preemie means for those of you that don't know. So don't sweat it. All right, how should you prioritize the order of the information that you need?
Are they going into labor or?
Okay, how would you ask that?
Are you having contractions?
Okay. What else?
Do you feel pain around your belly?
How far apart the contractions are?
All right. Anything else?
Would you do like the pain level?
There can be screaming. If they're in labor, there can be screaming. We can pretty much guess.
Okay, she's.
See, we're nice. Us guys are nice. Even though it was our fault. We're nice. And if we hear you screaming in pain due to childbirth, we're going to give you that 10. You got it. That's how nice we are. All right, we'll go over more questions. All right. What factors will determine whether there's time to transport the patient to the hospital? I'll give you a freebie. Luis mentioned it. The contraction time. Anything else?
If there's crowning.
If there's crowning.
See if the water broke.
Yeah. Yeah, they use that one, but it's not really one of the imminent signs. All right. So like I said, it's a natural process. It's been going on for a long time. This is one of those calls that we as EMTs don't want to get because it's a messy call. Actually, I had a partner. I was an EMT at the time. It was my first 6 months of working on an ambulance. So it was 98. And we get called for a woman in labor. So we drive, and he's an FTO too. So we drive, we get to the place, and he's kind of looking, and he's like, I don't know. So he just keeps on driving, does a U-turn, starts coming back, and fire is already there. They'd just gotten there. And so we pull over, we go in, And they're in there, the baby's out and on mom and everything. And so it was weird. This was San Juan Capistrano. Spanish name, right? Have you guys ever heard of San Juan Capistrano? The mission?
Yeah.
Las Golondrinas de Capistrano. That's where they go. Anyway, so the medic didn't speak Spanish. And he asked anybody, I'm like, yeah, I do. It's like, can you ask her how long ago she gave birth? So I asked the lady in Spanish, and she says, oh, about 5 minutes ago. If my partner hadn't kept driving, we would have probably been delivering that baby. In a way, I'm thankful, but then in another way. So I mentioned it to a couple of my coworkers. They're like, oh, yeah, he doesn't like to be first at scene. Like, not cardiac arrest, not anything. He doesn't like to be first at scene. That's why he kept driving. It's like, fucking shit. Here he is supposed to be this FTO, and he doesn't want to be first on scene. Doesn't want to teach right. Whatever. Anyway, I digress. But there are those times that will happen. To my colleagues out of Sierra Blanca, they delivered a baby on New Year's Eve or New Year's Day, one of the two. They're bringing her here to El Paso. One of my former students, same thing, out in Sierra Blanca. So the opportunity does exist. Now, fortunately, complications are not common. But we know women. They love to make our lives difficult. And they never tell us when they're going to make our lives difficult. They just do it. Be ready for those complications. And it's funny what they consider complications. We'll talk about those. There's a separate section. Okay? So understand that. I hope I can get you guys in soon. I have OB mannequins. So I want you guys to be moms and dads. In other words, I want you guys to push and deliver babies at the school with my OB mannequins. So, trying to get a picture. Of course, there isn't. Kind of, sort of. All right. So, first off, we know the basic female anatomy. They have ovaries. And they have fallopian tubes. The ovaries is where the eggs originate. They are released about once every 28 days during ovulation. It goes up into the fallopian tube. It travels down the fallopian tube. Now, the hope is that the egg itself gets fertilized within the fallopian tube. After it's fertilized, it keeps traveling, it gets into the uterus, it implants in the uterus, and it begins to grow. That's the process. So the uterus is a pear-like shaped. You guys taking notes?
Yes, sir.
The uterus is a pear-shaped organ that's very vascular, that expands as the fetus grows. Now, one thing I have to tell you guys, please understand, I've been teaching this a long time. I'm not putting in my political beliefs in this discussion by any means, or not just political, actually not really political, my religious beliefs. So don't take it like I'm instilling anything or whatever. When I look at the pictures, they look like babies. And so I will usually say babies, okay? When they're smaller, I'll say fetuses or embryos, but when other pictures, I'll say babies. Now, until they're born, they're not babies, they're fetuses. And I know that, but sometimes, like I said, I slip and I'll call them babies. Please do not take offense. Um, it's just I've been doing this a long time, and whenever I see a picture of a baby, I say baby, but I try to use the correct terminology. Okay. All right. So going back, so that embryo implants within the uterus. Now the uterus, there's several different parts. We have the fundus, which is the curved part of the uterus, the frontal part. And then you have the body, which is the main thing. And then down at the bottom, at the end of the vagina, is called the cervix. And so if you think back to another word that kind of has the first 5 letters of that, what can you think of? Hello?
Yeah, wouldn't it be cervical, like the cervical spine or something?
There you go, cervical, like the cervical spine. So cervix actually comes from cervical. And we even use that terminology, like cervical cancer, cervical opening. So what does cervix mean? Anybody know? A little trivia. It means little neck. Kind of weird, huh? Kind of neat.
Yeah.
So, sorry, trying to get my cookies. Gotta have my cookies for breakfast. All right. So the cervix is actually what dilates, what opens up to allow the fetus to come out. Otherwise, it's no, ain't happening. Now, remember the layers of the heart? The myocardium, the pericardium, and the epicardium?
Yeah.
Well, the cervix also has those layers, except instead of the cardium, it's called the endometrium, the myometrium, and the perimetrium. So the prefixes are the same. The suffixes are different because it pertains to the uterus. Now it's that muscle, the smooth muscle that contracts during labor. In other words, the mother's like, kid, I've had enough. Get the flock out of here. And the mother pushes. Involuntarily, of course, but she pushes. So again, when that fertilized embryo or egg, right now it's an egg, zygote really, when that fertilized zygote comes into the uterus, it attaches, and the uterus has been getting ready. That's what the female menstrual cycle is all about. It thickens up the endometrium. It thickens it up with blood because it's getting ready to receive a fertilized zygote. And here it comes, it attaches, and all of a sudden it's going to start developing and feeding it and doing everything that it can until 9 months later, you evict that little sucker. Okay? Now, question so far?
No.
Yeah.
All right, so within the uterus, as the fetus, as the zygote, and then the embryo starts to grow, it grows within a sac. And we call that the amniotic sac. Now, the other thing is, this kid is within this sac, is inside embryonic fluid. So for a while, it's just kind of floating, like floating in space, a spacewalk. Well, back before the jetpacks up in space, they were tethered to the space vehicle. Well, this kid needs to be tethered. So out comes, and we have a remnant of that, our belly button. Out comes the umbilical cord that attaches like an air hose. I'm trying to be funny. You guys are just dead today. Screw the Mondays. You guys are almost done. Just hang in there. Let's hear it. Remember, you guys have already done this. I'm just kind of having fun with this. So that umbilical cord goes to the what organ?
Placenta.
To the placenta. Awesome. All right. Now in the placenta, that's actually receiving stuff from the mother to be. And it sends it to the kid. And the kid uses it and then pushes it back out through the umbilical cord, back to the mother gets rid of it. So all that oxygen and the nutrients that the baby needs, or there I go, that the fetus needs, it's going through the umbilical cord to that fetus. The kid uses it, carbon dioxide, carbon dioxide, back to the mom, through the umbilical cord, to the placenta, filters it, puts it back in the mom's bloodstream. The mom's bloodstream gets rid of it. Okay. So, all right. So within the umbilical cord, there's actually one vein and two arteries that take stuff and come back. So if you keep going in EMS, you could even cannulate the vessels and the umbilical cord. Anyway, so within the like I said, the amniotic sac is amniotic fluid. Could be a lot of fluid, 500 or 1,000 cc's. And what usually happens, somebody said water breaks. Well, the reason I don't like water breaking out of a minute delivery is it could still be hours. Okay. Now they also call it bloody show. It could still be a while before that little squinkly comes out. So I don't like it. What the hell did I do? Oh, there we go. All right. Next part, the vagina. It's the lower portion of the birth canal. So it goes from the cervix to the vagina and then the vaginal opening. So as you can see here, you guys are able to see my picture here?
Yeah.
I need to
Yeah.
do an experiment. Shoot, I don't have it. And what the hell? Anyway, so here's so here is the uterus. I'm sorry. Yeah, that's all the uterus through here. You guys see my red pin? Including here.
Yeah.
Yeah.
All right. So here's the cervix right here. And there's that opening. So what happens is during contractions, what a contraction really is the uterus actually opening up to allow the fetus to be able to go through it. So that's what the contractions are. Quit it, it's too early. Okay. Now, within the uterus in here is where the amniotic sac is and covered in amniotic fluid. Now here you see the umbilical cord right in here. It's in the baby. Goes through there. And it ends at the placenta. Now notice the location of the placenta. All right. So guys, remember how I said it's our fault?
Yeah.
So here's the thing. You know how they go to the bathroom like every 2 minutes when they're pregnant?
Yeah.
And you're like, honey, this is all your fault, blah, 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 blah. Right?
Yeah.
Well, again, remember how we said it takes two to tango, but in order to make our lives happy, yes, honey, it is. This is the head, right here. Head. What's this right here? What's that organ right there?
The bladder.
The bladder. What is the head doing to that bladder?
Pushing on it.
Pushing on it.
it.
So what happens to the capacity of that bladder?
It decreases.
It decreases it. So how much do you think it takes to fill up that bladder, causing him to go to the bathroom?
Not much.
Not much. So therefore, ergo, it's your fault. That's why they're going to the bathroom a lot. Because as that fetus grows, it pushes on that bladder and there's less capacity, causing him to go to the bathroom a lot more often. Okay? Now, something else I want you guys to notice, but we're not going to talk about it yet. Let me change the color. Can you see my blue circle?
Yes.
As that fetus starts coming down to go this way, this area right in here is going to get smaller. Again, we'll talk about it in a little bit. But it's something to remember, okay? All right. So like I said, every 28 days, some stuff happens. Understand that the average is 28 days. Some women are more, some women are less. But on the average. And we talked about this last week, didn't we?
Yeah, I think we did.
Okay. So remember, about 2 weeks after their last menstrual cycle, that's when they're fertile. That's when they ovulate. All right. So what happens during the menstrual cycle is if the uterus doesn't get that fertilized egg, it's a little disappointed begins to slough off the extra blood in the layers that it created. Sloughs it off, goes down, it discharges it, and it's going to start getting ready again for another go round. Okay. Now, like I said, remember it's getting ready to receive a fertilized zygote, so it's getting itself ready. Hormones start getting released. So understand that's why they get cranky. Part of why they get cranky during their menstrual cycle. And then when they are pregnant and they really get cranky, just remember, it's not just a filable homicide if you kill them. If they kill you, it is. But if you kill them, it isn't. Okay? I'm just kidding for the record. But no, the hormones are really active because of everything that's going on, the developing fetus. Or in the case of the scenarios, fetus says. So. All right. Now, we talk about months, right? Now, I'm not so much worried about the first 14 days. It's a zygote, and then from the second and 8 weeks, it's an embryo, and after 8 weeks, it's a fetus. Okay, yeah. When we talk about pregnancy, what term do we use generally?
First, second, and third trimester.
Okay, we're not in the trimesters yet, but you're right. But that's kind of a medical term, though, right?
Yeah.
Because in layman's terms, what is it that we do?
It's gestation.
No? Come on, guys. Before this, you guys were all layman's. And so you're familiar with the terms that we use. Or not we use, that you guys use. I have 23 students in here. And not a single person has ever asked somebody how far along they are.
Weeks.
I'm not talking about medical.
How many months they are?
Thank you. How many months along are you? Because a normal pregnancy is how many months?
Oh, 9.
9.
9.
9 months, right?
Sir.
Everybody in here has either heard it or said it. How many months along are you? Right? Any moms or dads in here?
Yes.
Okay. And it was months, wasn't it?
Yeah, it was.
Mm-hmm. So nowadays, or now in the medical field, we don't use months. As somebody said, we use weeks. Okay. Normal gestation, and that just means pregnancy. How long that the woman is pregnant for. Or to be politically correct, the individual, because we have to adjust our pronouns due to the current state of affairs. So the individual is 40 weeks. That's full term. And really, any child that's born after the 38th week is considered to be full term. Anything below 38 weeks is considered premature. Just wasn't fully cooked yet, so to speak. Okay. So here's the thing. 20 weeks is about halfway. 24 weeks, if a baby is born at 24 weeks, it's going to be a big struggle. But they have a good chance. The way medical science is nowadays, they got a good chance. Wasn't long ago where 24 weeks was right at the envelope where it was pushing it. I think the lowest they're going, or that babies do have a good outcome, although it could be touchy, is about 22 weeks. I don't think we'll ever hit 20. I think that's just a little much to ask for. So we use what?
Weeks.
There you go. We use weeks. All right, we talked about the hormones. So like I said, hormones increase. Now, the other thing you have to understand, and we talked about this abdominal, a woman's blood volume is going to increase by what point percentage? Or did we not talk about this? Because you in the advanced class are just about neck and neck.
Wasn't it 40%?
45 to
There you
50.
go. What?
You said what? What percent?
40%. But somebody said something to 50, and that's why I was trying to clarify, but of course you guys talk and run.
It was 45 to 50.
45 to 50? Okay. Yeah, different books will tell you different things. Just understand on the average is about 40%. And so understand that the woman has to lose that 40% first before you can start seeing signs and symptoms. So is that a bad thing?
Yes.
Yes. Now, a plug gets on the uterus, on the cervix, to make sure nothing comes out. And the breasts are kind of large because they're getting ready to feed the baby, the baby once it's born. So lactation can occur. More volume, they need more oxygen, right?
Mm-hmm.
Because of that fetus that's developing, that's going to need a lot more oxygen. Plus, the body needs to break down more waste. Cardiac output also goes up. Heart rate goes up. BP it does decrease a little bit and then goes to normal. The blood pressure should stay normal because the mother's body is adapting to that increase in volume. That's why when you take a blood pressure on a pregnant female or a pregnant person, you need to determine whether they're becoming hypertensive, because that later on, we're going to find out, can cause major issues. So blood pressure on a pregnant individual is very, very important to obtain. Now, especially where I used to work at, I just realized I haven't heard Rosie. Should I be concerned?
I don't think she's on.
She's not saying much.
You should be concerned.
Yeah, she's not on. All right, we talked about going more, but anyway, there was one more. Oh, nausea, vomiting. Always used to had a female coming in with nausea, vomiting, usually vomiting. My first question was, what do you think?
Are you pregnant?
Exactly. Well, menstrual cycle, and then are you pregnant? And after that, were you drinking last night? Now, one of the reasons also we wanted to know about the possibility of being pregnant was because there was a medicine we can get for nausea, but we can't give it in the first trimester. So we needed to know if that was okay.
Why can't we give it to them in the first trimester?
Because it causes birth defects, including cardiac abnormalities due to malformation of the heart as a result of this medication.
Okay.
Is that reason enough?
Yeah.
Okay, just checking. They actually had a paramedic give it to a woman or to this gal that was pregnant. Just find out. Now it's funny. I'm reading the report, and right off the bat, I'm like, "She's pregnant." And I kept reading, and the medic's like, "That she's pregnant." And I look at the treatment. It says Zofran 4 milligrams PO. I'm like, "Wait, what?" No, 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 no. So, but anyway, they can vomit a lot. If you guys remember Duchess Catherine of Cambridge, or the Duchess of Cambridge, in her first pregnancy, remember she was hospitalized? Maybe not.
Yeah.
Why was she hospitalized? Thank you, Sequoia. I love you. I owe you another Starbucks.
It's because she was really nauseous that she couldn't, like she just couldn't like I guess she was just really weak.
Yeah, she was vomiting a lot. She was dehydrated. Is dehydration good for a growing zygote and embryo and fetus?
No,
Nope.
not really.
No. So that's why she was hospitalized, trying to stabilize her and maintain fluids in her. And the diagnosis was hyperemesis gravidarum. Ugh, I can't even say it. I say a lot of the words, not this one today. So they're just gonna be throwing up a lot. So you'll see signs, symptoms of dehydration. But the other thing, maybe jaundice, is you're just you got bile buildup that's going into the body. It's in the bloodstream, so that's why you do it. So the main thing is supportive care. As EMTs, we're limited. You can't give them Zofran, so I don't want to call it a home remedy, but it kind of is. You want things to settle the stomach, and really about the only medication that pregnant women can take is Tylenol. But crackers and a lemony drink, Sprite, 7-Up, yes.
Yeah.
You want to be careful with heavy drinks. Now, if they could tolerate, like Gatorade, Powerade, Pedialyte always works. Tastes horrible, but that works too. All right. So before you deliver, another thing that can happen is hemorrhaging. There might be bleeding. So part of it is, why are they bleeding?
It could be possible a couple of things.
Yeah. And that's what we have to kind of find out, because bleeding can be life-threatening. We don't want it to be life-threatening, do we?
No.
No, because now that fetus might no longer be viable. So causes of bleeding include things like, and we'll talk about the spontaneous abortion, but there could be things like placenta previa, placenta abruptia, although those occur late in pregnancy. Or in an automobile crash, we talked about a ruptured uterus. Or even an ectopic pregnancy. So something is causing the bleeding, and again, we don't want abnormal bleeding to occur. Some spotting can occur.
Do those usually lead to miscarriage or stillborns?
Stillburns are few and far between nowadays,
Mhm.
because they have the ability to see if that fetus is still viable if something were to happen. So, what was the other part? So stillborns are fewer, but the miscarriages, is that what you had asked?
Yeah.
Yeah, the miscarriages is included in there. All right, so, and there it is. So remember I said this is not a religious or political discussion, and I'm not instilling my views on you guys. When we talk about miscarriages in medical terminology, we use a different term. Now, the connotation that it has, we tend to think about something else. And that word is abortion. When we hear the word abortion, we think about an individual going to a medical facility or to see a medical healthcare practitioner to terminate a pregnancy. And again, that's medical terminology. So that's what we think about when we hear the term abortion. But in reality, an abortion is a termination of a pregnancy. And there's two types. The first one is the one that you see in front of you, which is a spontaneous abortion. And that, what it really means, the term that we use, is a miscarriage. So for some unknown reason, the body terminated that that pregnancy. So it's not a matter of someone going to a clinic and saying, do this, do that. It's a matter of the body just terminated the pregnancy. Okay. So, a spontaneous abortion usually occurs within the first 20 weeks, usually a little bit earlier, but so it's just getting going. And again, the body just rejects it, just eliminates it. And we'll talk more about that later, or in just a moment. So what's happening is the patient begins experiencing abdominal cramping, abdominal pain.
Hey, Lou, what did you say about the 20 weeks? Can you repeat that for me, please?
Yeah, a spontaneous abortion occurs within the first 20 weeks.
Thank you.
You're welcome. All right. So again, abdominal pain, abdominal cramping. You could have spotting. You could have vaginal spotting, vaginal bleeding. It could be in the pain in the lower quadrants. They might have like I said, with the spotting, they might use pads or towels or something to stop that bleeding. Now, for this, if a possible spontaneous abortion is occurring, if they've used pads or towels or whatever, take that with you. Because, and I'm not trying to be heartless here, I'm just trying to be technical. The products of the pregnancy might be within those pads or towels or whatever they used to help stop bleeding. Does it make sense?
Yeah.
Yeah.
Okay. All right. They'll inspect that stuff at the hospital to make sure all the products are in there. All right. So remember I mentioned remember we mentioned how the egg comes out of the ovary and it goes into the fallopian tube where hopefully it gets implanted or gets fertilized. And then it continues down, once it's fertilized, continues down into the uterus. That's the hope. There are times when that's not possible or that does not occur. What happens is what we call an ectopic sorry. An ectopic pregnancy, which means that the fertilized egg has implanted somewhere other than the uterus. The
I'm
egg
curious, how does that
implants-
happen?
What was that?
I'm curious, how does that happen?
It just does.
Now, is there a way that it goes somewhere else? Or is
Yes.
it just,
It can go outside of the fallopian tube in the uterus and go into the abdomen. It's not a tumor. Yeah, it can go outside into the abdomen. A lot of times it does stop in the fallopian tube, and that's where the embryo starts developing.
it's kind of weird.
Yeah. Here's the bad news. That's not going to be a viable pregnancy. What do I mean by that?
It won't turn into a fetus.
Well, it might. It's going to be a while, but yeah, it's not going to. That zygote, that fetus, will never have a life. It's going to get to the point where it's going to be starving for oxygen, because remember, there's no. It's going to need oxygen in order to grow. And it needs to get a placenta, it needs to get an umbilical cord, and without it being in the uterus, that's never going to happen. So again, an ectopic pregnancy is where the egg implants somewhere other than the uterus. Now, unfortunately, as that ectopic pregnancy grows, like let's say it stays in the fallopian tube, eventually it's going to stretch that fallopian tube out and it's going to rupture it. And so really what they have to do is what they call a DNC, dilate and curate, which they'll go in there and they'll remove the contents. Before it was kind of difficult to get pregnant again through that fallopian tube, but I think medical science now has improved. I know one of my very best friends, she had an ectopic pregnancy years ago, and so it was harder for her to conceive after that. So I don't know. This was years ago.
If it ruptures, could it be harmful to both the mom and to the mom too?
Yeah. Because especially if I mean, you got products going in there, so now you're talking about peritonitis. That sounds familiar, doesn't it?
Yeah.
Yep. Because you guys learned it in abdominal emergencies a couple weeks ago. So see, 6% happen in the abdomen, Mr. Paul. Most of them occur in the fallopian tube. For some weird reason, outside the wall of the uterus occurs, but again, that wall is preventing it from being right in here, or you guys can't see that. It's preventing it from being right in here. And man, this kid just wanted to get the hell out of there as quickly as possible, goes down to the cervix. It ain't happening. It needs to be within the wall up in here. See, more proof women are complicated. Right, guys?
For real.
Comment. So can have dull aching pain, can have vaginal bleeding, tender bloated, shoulder pain as well. But the key is in your interview. Remember what we've talked about. Date of your last menstrual cycle. And then is there a possibility you could be pregnant? If there is, and they're having all this abdominal pain, you got to be thinking about an ectopic pregnancy. Okay? So, usually for this stuff, it's position of comfort, maybe some O2. Not much else to do. Here's another one. And I do hope you guys are taking notes. Placenta previa. Placenta previa can occur usually in the third trimester. Now, when we talk about trimesters, it's 3 months. Weeks, I hate doing that math. But just remember, 4 weeks equals a month, so 12, 24, 36. First 12 weeks is the first trimester, 13 through 24 is the second trimester, 25 to 37 is the third trimester, something like that. So these usually occur in the third trimester, but placenta previa tends to be not painful, maybe a little discomfort. There might be some spotting occurring. Now, delivery might be difficult. And the reason why is because the placenta is right over the cervical opening. So what am I doing? This is what I'm doing. You guys are way too quiet.
It's on Monday.
I'm sorry, but your grandmother that's needing help, I'm just referring to everybody that's needing help, and she's counting on us to help her out. We can't tell her, sorry, ma'am, I have a feeling you're going to die today because it's Monday and we're not into it.
Yep.
There's like certain things you never tell me. Never tell me you're tired. Never tell me that it's a Monday. Never tell me that you don't feel like it. Yes, ma'am? I'm listening. What were you saying?
I'm saying it's just a Monday. I hate Mondays.
I think everybody hates Mondays because it's the start of a new work week.
Yeah, and plus I have to work.
I'm at work right now.
You're in the luxury.
You guys are
of
just
your
laying in
own
bed, kind of like, I don't have to get up yet. I had to get up early to get ready, although I'm not really ready, but I was running around. So I'm already at work. So what are you talking about? And then as soon as I get a break, I'm going to go take a shower and I'm going to go be in the office until 9:30, 10 o'clock tonight, 10:30 tonight. So I got a 15-hour day. How about you? See, somebody always has it worse.
Not really.
Yeah. Man, no sympathy from you guys.
Hey, Lou.
Yes, sir.
Wifey comes in from Afghanistan today at 10. I don't know if you remember me telling you that.
I remember
leaving
she's
a
coming
little
back
early.
today. I didn't remember what time.
Yeah, she comes in today at 10, so I'll be leaving here in a little bit to go get her.
Okay. Well, you got some experience with childbirth, so I'll cut you some slack.
Yeah, like 18 years ago.
Still, you got more experience than I do. All right, so as you see there, that's a uterus. You got the cervix right here, and then you got the vaginal canal underneath. Okay, so normally the placenta is up in here, or here, or here. No, I'm not making a redheaded dude. All right. So in placenta previa, it's down here. Well, how the hell is that baby supposed to go down? Out here and start ruining your life for the next 18 years plus. Just kidding. It can't, right? So that's when they do a cesarean. Come on, guys. Let it stop being a Monday. I know it's a Monday. Come on. You should be thankful I'm not doing to you guys what I did in the night class. They got an exam today. There's 2.5 chapters I didn't lecture on. And I'm not changing the textbook. Huh?
How does the previa even build up?
Do what? I'm sorry?
How does the previa even build up? Like, what is it? Like,
that's just where it developed.
Oh.
That's just where it developed. Topic previa. All right. Now, again, so this usually third trimester and can start happening as the cervix begins to dilate because it's separating away from the placenta, but minimal pain. So due to the slow bleeding, again, it's not going to be, might not be a lot, but there might be some bleeding occurring. Pain, like I said, minimal. So understand that they may go into shock. So just treat them. Oh, so there's the picture. You see? So the kid has a new hat. Now, the other thing that you might see is what we call abruptio placenta. So the way I like to think about these two is, and I remember getting a lot of OB questions on my registry exam, so expect it on yours. The way I like to think about these two is placenta previa is with previa, I like to think about previous. So it's right over the uterus. I'm sorry, right over the cervix. Whereas abruptio placenta or placenta abruptio, either one, the abruptio, I think about abruptly. And so what's happening is exactly what you see. You see where it says uterine bleeding? What's happening is the placenta is separating from the uterine wall. The placenta is suddenly separating from the uterine wall. This is going to be painful. And this kid can go into distress. Because why?
It's not getting the oxygen because of the bleeding.
Exactly. And the placenta is separating from the uterus itself. So it's a disconnect, literally. As far as for the mom to be, because of the bleeding, she can go into shock. So like I said, severe pain, more bleeding. So treat for shock, O2, rapid transport. Now, as for a ruptured uterus, something caused that uterus to rupture. Compression, or some other type of trauma. Now, a bad thing that can occur as a result of that, and depending on the size of the rupture, is it could eject the fetus into the abdominal cavity. Not a good thing, is it?
No.
No.
Nope.
So it does have a high mortality rate. You could have severe hemorrhaging, obviously, because of the ruptured uterus. And as we mentioned earlier, it's very, very vascular. The fetus can be in distress. So these are definitely, and that's why you have to have a high index of suspicion when you have automobile accidents and the patient struck their abdomen and they're pregnant. We got to think about that possibility. So there you have it, where the head is protruding through the uterine wall. Not a good thing. Plus, we have the bleeding going on as well. So if in your history you get a history of a previous uterine rupture, it means that the uterine wall is a lot more susceptible. It's been injured previously, so it's a weaker part, so it can rupture. More than 2 previous births as well. That uterus has been stretched before. So pretty much for any of these pre-delivery emergencies, position of comfort or shock position, give them O2 and rapid transport. There's not a lot that we can do as EMTs. So, questions?
No, sir.
No, sir.
No.
Let me do something. Hey, George, you better get going.
What? What was that, Lou?
Oh, not George. Paul.
Oh, I'm waiting for the kids to get dressed. Then
Of
I'm leaving.
course.
Yeah.
You excited, Paul?
Yeah, man.
Nice.
He's tired because he was busy scrubbing his house, eliminating all evidence of anything. Washing all his clothes,
Come on,
getting
Lou.
rid of any Monica Lewinsky stains.
Come on, Lou. I don't think my clothes like
I'm
that.
sorry.
It ain't that
But you
bad, Lou.
were.
It ain't that bad.
See, everybody knows the truth. Don't worry, we got you. Your
All right.
secret's with us.
As long as you don't know nothing, we're good, Lou.
It won't come from me, I'll tell you that much.
That's what I'm talking about. Bro
Same
code.
here.
We got you.
But whether other people let it slip, I can't promise anything.
I hope not. Sequoia.
Shut up.
Sequoia gave up my free beer the other night at Twin
Oh, you
Peaks.
missed it. We had fun.
Oh yeah. Threw you under the bus real quick.
Mm-hmm. All right, what y'all do? Y'all had something afterwards or what?
No comment. You had to have been there. You missed it.
Good stuff.
Yeah, you could have gone and come back, you know.
I could have.
But I don't know, so, oh well.
As long as y'all had fun. That's all that matters.
All right, so where were we?
Throwing Paul underneath the bus.
It wasn't me, that was you. Or at least that's what he's saying, that you're the one that's going to throw him under the bus.
No, Luis was there. Luis can vouch for that one.
Yeah, I saw that happen.
Who threw him under the bus? Me?
No,
No,
Sequoia.
Sequoia.
Oh.
I think how you guys are tag teaming me.
Not me. I'm on your side.
How does that feel, Sequoia? It's your turn now.
Yeah.
Too bad I gotta go pick up my wife. And Rosie's not here too. It's like we could have definitely tag team on me.
Oh, that could be arranged. Just because she's back don't mean you're not required to log back into class, mister. You get a set for her.
Just set up a what? An Uber? Oh, no, that would have been horrible. I would have had a horrible day if I would have did that.
It's like you said, honey, it's a bad day.
Mm-hmm. I don't want to make it worse.
I can't miss it.
But yeah, I am gonna get out of here. Y'all have a good day. I will see y'all in the morning.
Alrighty.
Have a good one, bro.
All right, man.
All right. So remember we've talked about seizures. And in those seizures, what happens is how much breathing is occurring? Breathing decreases, so oxygen levels decrease. And then all that possible jerking motion is dangerous, right? And what do we call it? Or actually, let me rephrase that. So a pregnant female that has a history of seizures or has had recent seizures ends up having status epilepticus. What is status epilepticus?
Epilepsy?
What was that? Did you say have blood pressure?
Yeah.
Well, that's one of the causes of what we're talking about. But no, I want to know what qualifies a person to be in status epilepticus. Just taking you back to medical emergencies, seizures.
Seizures that
Continuous
last like 30
seizures.
minutes, right?
More
What was
than
that?
30.
They're like seizures that last long, like 30 minutes, right?
Okay, what else?
And you have to have like 2 or more of them to be considered it.
Okay, what about 2 or more?
You don't recover fully.
Okay, but I want to know what makes a person status epilepticus.
I don't know.
So it's the new one is a seizure lasting more than 30 minutes, although when I went through it, it was lasting more than 10 minutes. Somebody said 2 seizures. I want more information.
It's when you have 2 or more seizures without fully recovering in between those seizures.
Okay. So having a second seizure before regaining consciousness from the first seizure.
Correct.
And what's the other one?
Is it just having a seizure in continuously?
We already mentioned that. How about 3 more seizures in an hour? No comment?
Yes.
All right. Okay, so seizures are not a good thing for pregnant women. Obviously, like I said, lack of oxygen flow, it is going to affect the mother, but more so the fetus, and we're worried about that. So what happens is that a big cause of these seizures is what we call pregnancy-induced hypertension. Pregnancy-induced hypotension. I'm sorry, hypertension. As that pressure increases, because of the abnormal hormone levels, or higher, I shouldn't say abnormal, higher hormone levels, it will have an effect on the person. And PIH used to be known as preeclampsia. Not a good thing for a pregnant woman to have. And then in the third trimester, it becomes eclampsia. So that's why they need to seek prenatal care to make sure everything is going okay. So they might already have some health conditions to begin with. They might not be eating very well. Anything that causes blood pressure to increase is not a good thing, like salts. Because what starts to happen is they start retaining fluid. So even though they're going to have swollen ankles, this is something that's not relieved. And so that can be a sign of them being preeclamptic. So really what we need to do is we need to transport them on their left side. And remember, we've talked about this next one, supine hypotensive syndrome. Wasn't that on an exam not too long ago?
Yeah,
Yes.
last week.
Yeah. And so why do we place them in the left lateral recumbent position?
To relieve pressure off the
The vena cava.
Which one? There's two of them.
Inferior.
On the inferior vena cava. All right, good. Chingao. I don't care what. All right. All right. So in general, we show up. They might tell us they're pregnant. They might not, as far as dispatch goes. Hopefully they do. But you show up and you never assume they're pregnant. Okay? Just because they look like it, don't ever assume it. You want to get slapped in the face or kicked in the nads? You get somebody over, this young lady that's overweight, and you say, "Oh, when are you due?" Big mistake, right, ladies? Man, class is boring today. Hello? Can you guys hear me?
Yes, sir.
Yeah,
Loud
we
and
can
clear.
hear you though.
Okay.
Yeah.
Just number one, say anything. I'm hearing from Demia, from George, from Luis, and Sequoia. 4 people. I heard from Valerie a little while ago, 5, and Paul when he was here, 6. And I got like 20 of you in here, 19 of you. Caesar, where are you going to ask a patient?
Like if they're experiencing any pain?
So you show up for whatever call, and the first thing you're going to ask them is, are you experiencing pain? I want you to walk through. You walk into that living room, and you got your patient on the couch. Ow, ow, ow. What do you think? Think they got pain?
Yeah, they probably have pain.
Okay, so you go up to her. What do you do? I don't want to hear BSI scene safety.
Ask them what seems to be the problem.
A total stranger is going to come and touch my wife.
I mean, before that, I'll probably introduce myself, saying
There you
hi.
go.
My name's Caesar. I'm here to help. What seems to be the emergency?
What's going on today? Because if you start talking emergency, they're like, oh my gosh, wait, what? What's going on? No, please don't tell me that. So what's a better way to word it?
I'm not really sure, honestly.
Hi, ma'am. My name is Caesar. I'm an EMT. What's your name? Sequoia. Hi, Sequoia. What's going on today? Take it away, Sequoia.
What, being the EMT or being the patient?
You're the patient.
I'm having pain.
Ow, ow. All right, so what next, Caesar?
Ask them like when they started.
Talk to her directly.
Like when did it approximately started?
About like an hour ago.
Is there any particular area?
In my stomach area.
If I'm there, could you just point it, see where it's centralized?
You're using technical words for her.
No. Can you show me where it's hurting? Which area?
It's hurting below my belly.
Below the belly. Do you happen to be pregnant?
Yes.
Ooh, you just called her fat?
No, I'm asking if she might be pregnant or if she. Yeah. Do you know your trimester?
Wait, what?
No. I think I just found out like 2 weeks ago.
2 weeks ago?
All right, so 2 things. Remember to ask, first question to ask is, what was the date of your last menstrual cycle?
Okay.
And then if it's past the 28 days or past a month, then the next question could be, is there a possibility you could be pregnant? So see, she said she just found out she was pregnant 2 weeks ago, and you asked her, are you pregnant? Okay. Well, how did you know she was pregnant if she only found out 2 weeks ago?
Okay, yeah.
Are you like hoodwinking at her or behind the husband, lover, son, or whatever, side piece back? It's a small town. What do you expect? Just kidding. So, so she found out 2 weeks ago. Okay. Now, the other thing too is, remember what kind of questions you want to ask in abdominal pain.
Ask them about their. Wait, are we just talking about abdominal pain in general, or just with pregnant women? I don't know.
Abdominal pain in general.
It'd be the OPQ-RST.
There you go. OPQRST. All right. So we know she's pregnant. Now, the other stuff you want to be asking, and this is also going to come into play once she's in labor, is the first question. If she says she is pregnant, the next question should be, and again, I hope you guys are taking notes, is what is your due date? Then you want to ask, who's your doctor? And along with that, have you been seeking normal prenatal care? The next question, if they have, is does your doctor expect any complications? Does the doctor expect any complications? So we went over the assessment. You want to determine whether they're having abdominal pain. You want to determine what the date of your last menstrual cycle was and possibility of being pregnant. If they do tell you they're pregnant, how far along are they? Then, like I said, PQRST questions or OPQRST. Now, the other questions too, once if they tell you they are pregnant, other important information to gather is, have you been pregnant before? And if they tell you yes, how many times? The next part is, all right, how many deliveries have you had? Or I should say, live deliveries have you had? Or actually, let me rephrase that. That 2 is a 1. And so, are you noticing what I'm doing? And she tells you, oh yeah, by the way, I had a miscarriage before. What did I just write out?
One abortion, one pregnancy.
Nope.
Or is that a 2 or a 1?
That's a 1. So we go from left to right. So in our rating report or in our written documentation, we would write she's gravida 3, para 1, AB1. So that tells us she's currently pregnant with one kid. Gravida means pregnancy. The para, so paragravida is live births. So gravida 3 means she's been pregnant 3 times. Paragravida or para 1. So either she's pregnant with twins or she had a miscarriage. And with the AB1, that tells us that was a miscarriage. So again, AB abortion, but it's not what you think. Now it could be, but usually we're going to look at it as a miscarriage. All right. Did that help?
Yeah.
Yeah.
Okay. So as far as other things you'll see in your secondary, we talked about a lot of them: abdominal pain, bleeding, cramping, weakness. You might see them pelvic clammy because of signs of shock. You might see swelling at the ankles, the feet, the face, crankiness, ultramental status. So the main thing is provide O2, position of comfort. Remember, usually we're gonna that position of comfort really is on the left lateral recumbent side. If they're under the 20 weeks, that fetus is not big enough yet. We really don't have to worry about it. But after that, we do. Oh boy. Keep an eye on the mom, making sure she's not feeling weak or dizzy. Nothing else is going on. The big thing here is if the mother to be goes or is in cardiac arrest, we're going to go ahead and treat her aggressively. And the reason being is that we want to at least try to save the fetus. Yes, we want to try to save the mother as well, but if we could save the mother or prolong the mother, the fetus is going to stay viable as well. So CPR becomes more important in this situation. Remember that the mother's circulation status is going to affect that fetus. So we need to maintain it as much as possible. Okay?
Got it.
All right.
Yes.
All right. So the next step, the next section we're talking about is going to be labor, the process of labor, of delivering that baby. So to me, it's a natural break, especially considering the time. So go ahead and take a break. Be back at 10:15.
Sounds good.
Okay.
All right.
All right. I'll see you guys at 10:15. All right. See you in a bit.